Good evening, everyone. I'm Dr. Ramanathan from Singapore, and my talk today is on one of the common aspects of that we all face when you have patients on ECMO. I've been asked to talk on ECMO in septic shock. Just a second. Okay. Oh, okay. Let's get this off. Yeah. Okay. All right. So it's as I said earlier, patients with septic shock are often referred for ECMO, and uh, it's sometimes decision making on the utility and futility of ECMO in septic shock can be tricky. So before I dive deep into how ECMO works in septic shock and in which scenarios it's very helpful, just a few aspects to brush upon septic shock per se, so that we understand how ECMO can be useful in scenarios pertaining to septic shock. Now, at the outset, you need to understand one thing. This was a paper published, say, about 40 or 30 years back, 35 years back, where it was observed that during sepsis, there is always a reversible myocardial dysfunction. So clearly, one thing that is less defined or poorly defined is the involvement of heart in sepsis and septic shock. There is an entity called a septic cardiomyopathy that is poorly defined. It happens in less than 5% of patients with septic shock. But having said that, a reversible myocardial dysfunction almost invariably happens during sepsis. There are specific infections which have a preponderance towards myocardial dysfunction. So viruses and bacteria such as pneumococcus have been shown in pathological slides to cause cardiac scarring. So going on to say that some of these organisms are cardiotropic. Mind you, it's not just the organism alone that causes damage to the heart in sepsis. In patients with septic shock, you end up starting them on catecholamines to counter the vasoplegia. And such patients, they do get some element of catecholamine-induced myocardial dysfunction. A very few patients do develop catecholamine-induced cardiomyopathies too. Reversible cardiomyopathies or left ventricular dysfunction states such as Takotsubo cardiomyopathy has been described in patients with septic shock as well. Now, this is a very nice paper published about 10 years back by Marco Cecchoni and Antoine Baron in ICM, where they showed that there is a depressed myocardial performance in 100% of the patients with septic shock. Most of the time, it's LV systolic dysfunction. Sometimes it's LV diastolic dysfunction. And very often, it can also present as RV systolic dysfunction. Going on to say that the pattern of myocardial dysfunction or depressed intrinsic myocardial performance has been something that has intrigued a lot of clinicians in the context of septic cardiomyopathy. Now, it is with this background that I introduce you to how ECMO is going to be useful in sepsis and septic shock. Clearly, I've given you a clue that it's the cardiac dysfunction that's going to be helpful when you use ECMO. And to substantiate that, I'm going to throw you a few recent papers in a logical way so that you understand where and how ECMO can be useful in this context. So the initial papers on the use of ECMO in sepsis and septic shock comes from the pediatric world. In fact, the outcomes in pediatrics were quite good, to the point that Dr. McLaren, when he published the outcomes of central ECMO in refractory pediatric septic shock, 80% of his patients survived to hospital discharge. Going on to say that it's a huge number for pediatric septic shock patients who are otherwise deemed or doomed to die to survive, and that too, such high numbers when it was used in the context of central ECMO. Not just that, following these series of papers, the American College of Critical Care Medicine, as well as the Surviving Sepsis campaign, in its guidelines for the management of pediatric and neonatal septic shock, made sure that ECMO was a treatment option in refractory septic shock in pediatrics and neonates. So I reiterate, in pediatric patients and neonates, this is already a part of the algorithm for management of septic shock, and it is considered in refractory shock. How about adult patients? Now, one thing about adult patients we can be proud of is the initial papers on adult septic shock and the use of ECMO came from Asia. A lot of papers from Taiwan and Korea, which went on to highlight the futility of ECMO in adult septic shock. So if you look at this series from Taiwan, only 15% survived to hospital discharge out of a group of 52 patients. The point I'm going to highlight here, and this is going to be something which I'm going to deduct eventually as to when ECMO would be used in septic shock. Now, all these patients went on veno-arterial ECMO, and they all had normal LV function. This is in the group of, this is from the Taiwanese study, where the survival was as dismal as 15%. Now, this was a paper from Park and colleagues in Korea in and around the same time, where they cannulated adult patients in refractory septic shock. Here, these patients had an element of septic cardiomyopathy, but unfortunately, about 75% of their patients had cardiac arrest, and ECMO was used as part of ECPR. Their outcomes were equally bad. None of the patients in whom ECMO was initiated 30 hours after the onset of septic shock survived. And clearly, there were some glaring signals here as to how much ECMO would be efficacious in septic shock. Now, that put forward a major question. Why is ECMO effective in pediatric septic shock or neonatal septic shock, but it's clearly not effective in adult septic shock? Similar kind of picture was seen in another Taiwanese paper, where they looked at a multivariate regression and predictors of survival. Clearly, things such as CPR during ECMO, the need for VA ECMO, as well as an increasing age showed poor prognosis. Going on to say that such patients are not good if you are going on ECMO. But then that also begged the question, if these patients are not good for or good on ECMO, who are those patients who are ideally suited to go on ECMO? Again, their overall survival was very low as well. Survival was even lower with VA ECMO. Now, this To answer this question, if you look at the pattern of septic shock amongst the varying age groups, that probably explains the difference in outcomes in the studies that I outlined so far. So in pediatrics and neonatal septic shock, VA ECMO works, while in adolescent or in adults, it doesn't work. That's mainly because in neonates, septic shock presents predominantly as right heart failure or persistent pulmonary hypertension of newborn. While in pediatric patients, it's predominantly a left heart dysfunction. By the time these children become adolescents and adults, the pattern of septic shock changes to more of a distributive shock with minimal cardiac involvement, for which I showed the evidences in the beginning. Now, with this concept in the background, now I'm going to show you a study that was published again. This was one of the first studies in adults that showed good outcomes in bacterial septic shock. Mind you, their numbers were very low, but then these numbers were very low because they opted to choose a particular profile of patients who would benefit from ECMO or veno-arterial ECMO in this context. So these patients had an EF of less than 25%. They had a low cardiac index and high vascular resistance. And in this context, these patients were offered ECMO. And what did they find? They found that these patients survived. About 70% of these patients clearly were rescued by ECMO. And this clearly mirrors what Graham showed in his pediatric paper as well, where 80% survived. But mind you, that was in a group of children, but in a group of adults who have a full-blown septic cardiomyopathy, they benefit out of veno-arterial ECMO as a mechanical cardiac support device. Now, the same group followed this up with a nice paper in Lancet about 5 years back or 4 years back, where they looked at a bigger cohort of patients with septic-induced cardiomyopathy and cardiogenic shock. So all these patients had mixed shock, septic shock with cardiogenic shock, and they were offered VA ECMO. Their outcomes were very good. And in fact, even after propensity score weighting, ECMO remained associated with improved survival. In an editorial to that particular article, Graham wrote that sepsis-induced heart failure, ECMO can be considered to provide cardiac support. Even though the study doesn't provide definitive proof, this is the strongest evidence to date in the adult population as much as septic shock goes. Now, we followed that up with a systematic review as well as an IPD analysis. Our findings closely mirrored what was shown in the Paris paper. We went on to tease out where exactly that cutoff point for VA ECMO should be chosen. Based on our analysis, we figured out that patients who had an EF of less than 20% had about 65% survival rates as compared to those above 35% EF who only had a 30% survival rate. Quite mirrors what the Taiwanese studies showed. So, if you were to summarize the literature and make some notes from this, ECMO clearly works in pediatric population because of the pattern of septic shock there, while in adults, in a specific group of patients who have septic cardiomyopathy, you will have to opt for VA ECMO. Now, what about those patients who are regularly referred with community-acquired pneumonia and they have inotropes ongoing? They are still in septic shock. A lot of them, by virtue of ARTSNet ventilation, will have some element of RV dysfunction, which would contribute to the shock. Now, in such scenarios, as much as RV dysfunction is mild to moderate, clearing the hypoxia and correcting the acidosis, the respiratory acidosis created by your ventilation, usually corrects the RV dysfunction as well. And in that context, patients with ARDS who have mild to moderate RV dysfunction are best treated with VV ECMO. So the use of venous ECMO in septic shock patients is clearly delineated by their degree of RV dysfunction, while patients with biventricular failure or severe LV dysfunction would benefit from veno-arterial ECMO in this context. Now, our paper was essentially followed up by a series of other papers as well from Karolinska as well as from NHS UK, where similar kind of outcomes were shown. In fact, the Karolinska paper showed that the hospital survival was as high as 90%, and the ejection fraction of such patients were only 25%. So the bottom line, which I'm trying to summarize here is both VV ECMO and VA ECMO are used in patients with septic shock. VV ECMO in those patients with RV dysfunction, especially mild to moderate. We know arterial ECMO in those patients with LV dysfunction. Mind you, those patients who need veno-arterial ECMO as a MCS device will eventually need conversion from VA to VV. And this is guided by serial echocardiograms. Now, the take-home point at the end of this lecture, which I think you should know, is clearly, we all know that ECMO in layman's term is artificial heart and artificial lungs. The centrifugal pump acts as the artificial heart while the oxygenator acts as the artificial lung. In septic shock or in any patient for that matter, ECMO can always support your heart, ECMO can always support your lungs, but ECMO can never support your capillaries. So patients with pure distributive shock will never benefit from ECMO in any condition. They need to have an element of cardiomyopathy or LV-RV dysfunction in varying orders to be supported either by VV ECMO or VA ECMO in their respective contexts. So just for those who would be interested in looking at a decision-making algorithm for ECMO in septic shock, if you are referred a patient, clearly, the first and foremost things that you look for is does this patient have severe hypoxemic respiratory failure or refractory hypoxemia? And in this context, an echo gets done to decide whether there is right ventricular dysfunction or biventricular dysfunction. If it is right ventricular dysfunction, which is mild or moderate, you offer them venous ECMO, while those with biventricular dysfunction or left ventricular dysfunction, they get veno-arterial ECMO. This is just a guiding principle when it comes to decision making for ECMO in septic shock. For patients who do not have cardiac dysfunction, ECMO will not be helpful unless and until you just use it for the sake of ARDS. Veno-arterial ECMO will not be indicated in such cases. I think I'll stop here and take your questions. More than happy to answer them.